strengthen really both the collection and the reporting of DSD within HIV routine monitoring systems, with the ultimate goal of improving treatment outcomes and programmatic efficiency. So that's what we want to see. And so this new section includes some recommended indicators for monitoring DSD-ART, some key considerations for countries to think through, which are important from an M&E, and then the recommended data elements to really capture in client records or EMRs, electronic medical records. And just to say, the tools and the minimum data set for HIV and testing have all been updated to enable monitoring of DSD-ART and are available as annexes in the guidelines for countries to use. Ooh, sorry. I see sorry about that. We just have a problem with the slides. So, okay, here's where we want to be. So as I mentioned, WHO recommends 5 priority indicators for monitoring DSD-ART. And these are the indicators that are deemed as essential. So really the minimum to be able to track through routine monitoring systems. But of course, countries may wish and need to adopt additional indicators for more in-depth monitoring to look at issues such as quality or efficiencies, and also use other data sources such as community-led monitoring. So the first indicator is multi-month ARV dispensation, which is the proportion of people that are currently on treatment that are receiving a 3 or more month supply of ARVs. And this is designated by WHO as a core indicator. So really critical that countries can track and monitor. The second indicator is on the uptake of DSD-ART models, which is important to monitor the rollout of DSD. And then the third priority indicator is really important. It's on coverage of DSD-ART models, and it enables us to assess whether individuals who are eligible for DSD-ART are actually receiving those services. And then the fourth and the fifth indicators critically measure the key outcomes of retention in care and viral load suppression. And WHO recommends these indicators so that countries are able to assess treatment outcomes and hopefully demonstrate improved viral load suppression and retention in care. So really important for countries to be able to monitor this through their routine monitoring system. Okay, so as I mentioned, the guidance also includes some key considerations for monitoring DSD-ART to help countries think through what are the key issues to address. And in the interest of time, I'm just going to concentrate on 2, shown in the red here. So firstly, ensuring timely and secure flow and linkage of data between community and facility data systems is really important, not only for integrated monitoring, but more importantly for integrated care. And just to highlight that the WHO recommendation here is that the facility-based client monitoring system, so that's the EMR or equivalent, remains the main data system that should capture all the key information for monitoring DSD-ART for clients, irrespective of where those services are delivered, be it in the facility, the community, or private settings. And secondly, to highlight that regular review of data and strengthening the use of data is really critical to address programmatic gaps and improve the quality and coverage of DSD-ART. And what that entails is really building the capacity of a range of stakeholders at all levels to be able to interpret the data so they can use data, creating regular opportunities where data is reviewed and interrogated and it's linked to quality improvement, and making sure that data is available on a timely basis when decisions are actually being made. So moving on now just to speak about where countries are in terms of their M&E for DSD-ART. So this is summarized in a policy brief that WHO published this year. There are copies at the front of the tent. And this is really pertaining to the Afro region. So we can say that we've seen some very encouraging progress in terms of countries introducing indicators and analyzing their data and using that data for service delivery improvements. And countries have really invested in a range of activities to support this, including updating their M&E tools, their EMRs, and capacity building of healthcare workers. So they've made real investments in this area. But where we are seeing variation is in the indicators that have been adopted by countries, which obviously affects the depth of monitoring. But most, at a minimum, are able to track the number of clients enrolled in DSD-ART models. Critically, where we're seeing gaps in monitoring is in monitoring viral load suppression and retention through routine monitoring. So with the exception of a few countries in the region, such as Zambia, which we'll hear about, most countries are relying on ad hoc data collection exercises where they're going into the facilities and collecting this data from patient records, which is obviously very time-consuming and resource-consuming. So what we want to do as WHO is support countries so that they can monitor these outcomes to improve services and quality of programs through routine monitoring. We're also seeing gaps in the monitoring of advanced disease and the recommended package of care, and the screening and management of non-communicable diseases and family planning, all of which will require the integration and linkage of data across systems such as the lab, but also across different service delivery areas and programs such as TB. Lastly, we're seeing gaps in monitoring key populations, and this is again an issue for countries in the region, with most relying on data from partners to be able to monitor access and coverage of DSD-ART models and outcomes. I think, so to conclude, I think we can say that progress has been seen, but there's really a need to strengthen the monitoring of DSD-ART to improve implementation. And this is very much doable. We've seen countries doing this, but it requires enhanced data use to really improve quality, coverage, and impact by a range of stakeholders at all levels. And to support countries to do this, WHO recommends 5 priority indicators to monitor implementation and outcomes, but these really are the minimum. And this in turn requires the integration of DSD-ART into EMRs and re-attune monitoring. And looking ahead into the future, WHO will be supporting countries to ensure data quality, both in terms of assessment and improvement in the disaggregation and use of data, to address gaps not only for DSD, but treatment outcomes for specific populations such as children, adolescents, and pregnant women in key populations. And then thinking ahead to the future of DSD as it evolves beyond HIV to include other services, there's a need to work towards improving integrated monitoring and interoperability. And that was my last point. So just to stop there and acknowledge the many people who contributed. Thank you.
Thank you very much, Iwad, for this great overview of the WHO Strategic Information Guidance. So now I wanted to give the floor to Dr. Stephen from Ghana, who will present the Ghana experience on data use for DSD testing implementation. Over to you.
Thank you. Good afternoon. I want to thank WHO for this opportunity for this opportunity to share the Ghana experience with you. So now let's come to Ghana. Ghana has a population of about 31 million. The prevalence of HIV in Ghana is 1.7, adult prevalence. And prevalence amongst pregnant women is 2%. Prevalence amongst female sex workers is 4.6%. It is 12.3% in STI clients. And this moved from 18 to 26% in men who have sex with men. And transgender women is about 40%. It's very high. We have an estimated population of people living with HIV, 354,927. So if you run it up by about 350, 7% of them are children. And as far as our 95 is concerned, we are at 72, 87, and 68. Prevalence of HIV in TB clients 14. And then also our mother-to-child transmission rate, when it comes to estimated new infections, that's about 17,000 every year, 9,000 new deaths. 17% of the new infections are in children. About 23% of the deaths are also in children. So this is the context, of Ghana. We started our differentiated service delivery in 2018. Next slide, please change for me. And since then, we have been able to put in place an M&E system to try and track our progress. And when it comes to testing specifically, the biggest yield is coming from the lowest yield is among pregnant women, and then the biggest is the partners of positive clients. And this is through the index testing. And in between, you find that men who have sex with men and all that. It's important to know that we have 2 approaches to testing. The community-based, facility-based is the second. The community is the second. And for each of them, there are different settings for testing. If you take the facility-based, you have client-led testing, and then also routine offer, and in various settings. And then also, the community-based. We have outreach, screening together with even the tuberculosis control program. And we do all this, together. It's important to know that when it comes to data collection on differentiated testing, we have a monitoring system that comprises a manual-based paper data collection, but the reporting is electronic through the district health information management system. And we take various indicators from different tools, from the HIV testing register, from the ANC register, early infant diagnosis register. And then we report monthly, electronically. There are different indicators that we look at: the demographics, the age, the gender, and then specific indicators that we look at when it comes to these tools. The next slide is how we have used the data to strengthen differentiated testing. And one of the key areas is for antenatal testing, looking at syphilis and HIV. In fact, through analysis of our data, we realized a low testing of syphilis compared to HIV. And it's the same pregnant woman who comes, and yet there was a gap. But then we introduced the syphilis HIV duo combo. And once we used that gap, we introduced that intervention. You can see from the curve that from a particular year, that was about 2020, we caught up. So now you can see that the numbers tested for syphilis is the same as tested for HIV. Okay, and that is the positive impact of data. And this came through stakeholder engagement, test case assessments, and capacity building and all that. So, ladies and gentlemen, what were the lessons that we learned, from all these? The lessons were simple. We realized that integrated monitoring in RM and CH for dual testing streamlined reporting and reduced reporting time. There was also an improvement of quantification. Look, the cost of quantification procurement, reduced by about 16%. And then also we were able to deploy retesting register, which helped to deduplicate some of the tests. But there were challenges. The challenges are that we still have the manual system. We need to make sure that we go electronic monitoring, system. There's a challenge with linkage from testing. So from testing and then to linkage, and to make sure that that continues, is very important that we fill that gap. And then also the fact is that not all our facilities have electronic management systems. Some are still paper-based. So going forward, we intend to scale up our electronic management system and make sure that we establish a case-based surveillance to be able to track people from testing to treatment. And then we'll be able to monitor some of the indicators that he mentioned, looking at multi-mount scripting and all those things very seamlessly. And then also to make sure that we continue to intensify monitoring and supervision so that we strengthen the system. So maybe next year, by the grace of God, another time that we meet again, we should be able to give you outputs of this system we are scaling up and to tell you the progress that we've made as a country. But it's clear that having a very robust MAE system helps us to be able to pay attention to specific areas, differentiated testing, to institute quality improvements, and to ensure coverage. So I want to thank you very much for your audience, for listening to us. And I acknowledge all our partners who have contributed, foremost the Global Fund to fight AIDS, TB, malaria, who supported us, our Ministry of Health, our Association of People Living with HIV, the recipients of care. They are the center of our care, and we really appreciate them a lot. Thank you very much for your audience. Thank you.
Thank you very much, Dr. Stephen, for sharing the experience of Ghana on the use of data to improve DSD testing. And now I would like to give the floor to Dr. Sivile from Zambia, who will present the Zambia experience on the data use for DSD art.
Good afternoon, everyone. Thank you, WHO, for inviting the Zambia program to come and share our experiences in operationalizing our differentiated service delivery program. I lead treatment and care at the Ministry of Health, and we appreciate the guidance from the documents from WHO. So, sorry, slide. We have different slides. Yeah, so this is a bit about Zambia. We have a prevalence of 11%. Total people living with HIV close to 1.5 million. New infections are 28,000, which is about 0.3% more in females than in males. The FIA that we did, Zamfia, in 2021, gave us 89, 98, and 96. Our program data will put the first 95 to about maybe 96. And right now we have over 1.2 million and 50,000 people on treatment. So this is just the background on, on our program. Yeah, so with regards to DSD, you know, our desire has always been to provide patient-centered care and improve the experience of our patients. We started the DSD program in 2017. We have both intensive and less intensive models, which are operational. We do provide also DSDs for children, key populations, and adolescents and young people have specific models. Right now, the core indicator, as Howard put it, we have for MMD, it's about for 6 months, 74%, fluctuates over month, as you would imagine. But if you put it above 3 months, we are at 94% of patients are receiving ARVs for more than 3 months packages. We do have both facility and community models, as shown on the slide. Our M&D process for DSD, as Howard has said, we thought from the initial inception of the program that probably we'll need to track longitudinal data at patient level. And so we used our, we used our electronic health record system. And a bit of the data comes from the DHIS2. So this map just shows you how many facilities we have, which have an AMR, about 1,650 out of about 2,600 facilities that provide ART. We do collect some non-routine data from surveys and research and that sort of thing. Data sources, primarily they come from ART forms, which are on the interface electronically on these electronic medical record system. Some facilities do have some paper-based, but those are a few. We do also have some registers. Most of these registers are auto-populated by our system, but we do also have a few registers which are manual. We conduct some data quality activities in the facilities to just ensure that the data is okay. This slide, next slide, just shows our interface. You can see that we do have an interface where you can collect all the models in our, you can tick for DSDs. And our indicator frameworks, we have updated it where we do have outcomes indicators, including viral load, suppression rate for those on DSDs, and also retention in care for those on DSDs, and a lot of other indicators. But these are probably the indicators of importance to our discussion. How have we used our data? The first thing is we've used the output from the data to increase our multi-month description. Over time, this has grown from 40% to about 80, 95, keeps on fluctuating. But again, the DSD data helps us in our our quantification processes. Initially, when we started and moved patients to our MDDS, we thought that there was a need to have these 180 packages of ARVs. And it's usually difficult as a program to start, partitioning. And the DHD data is very critical to know how many different packages you are going to procure. So the data is very useful, and the policy has changed as a program. Suppression rate has actually increased to 98%, as you saw in the survey, and this is program data. But we did carry out an analysis because we have a database of over 2 million records in our central repository. When we did the analysis, we in a longitudinal manner, one of the things that we have found was suppression rate was less in adolescents and young people, and also DSD models were less in that population. Secondly, men were also less likely to be in a model. And so this gave us a reason to do a few interventions with partners, as I'm going to explain. We also had some qualitative use of the data. We do have some activities in facility, because this data is analyzed at facility level, where they try to change the flows to increase experiences, things like waiting time, congestion, and so on. So all those things have actually improved. Of interest is the fact that our recent analysis from our smart care shows that our actually retention in care, about 96%. I know Samir, scale of our program from the Global Fund, will be amazed. Yeah, but this is at national level. At facility level, attrition is, say, around 8%. But at national level, because patients move around, it has gone up to 96%, and only 4% are falling off out of care. So this just shows some of the activities that we've used. Things like we've had support from Global Fund to have a men's clinic model, which is in 27 facilities because men were left behind. We've also have dashboards at facility level for AHD. And these are the key lessons that we've learned. Obviously, the main thing is that EMR is probably the best way to track these records longitudinally, and there's a lot of evidence you can get from there. We've also want to appreciate some of the catalytic investments we've received from partners. Our next step is to have routine generated records monthly, which we can use in our TWG, and also include a question on DSD in our CLM. Our analysis shows that probably we've left communities behind in our whole implementation cascade for DSD. And these are the acknowledgements. Thanks to, obviously, the Ministry of Health. IHM is the one that takes care of our HR and other siders that are our partner in this program. Thank you very much.
Thank you, Dr. Sivilé, for this very interesting presentation. So before handing over the floor to Kafui for the panelist discussion, I would like to thank again our three speakers for their very complimentary presentation, and I would like to request from the audience another round of applause.
Thank you, Celine. And so we've had really insightful and interesting updates that are primarily based on the health service side of things. And one other side of DSD that's important, and in data and SI generally, is the community aspect, a critical part, but sometimes forgotten. But thankfully on this panel, we have our colleague Jean from Rwanda, who will give us some insight into how data collected from community engagement tool, he will explain the details of it to us shortly, has shaped the implementation and decision-making around differentiated service delivery in Rwanda. So basically, Rwanda was among 20 countries that were supported to implement the community engagement tool. Jean, could you briefly elaborate on what the implementation of this tool, the key lessons learned, its rollout, including at least 2 challenges, 2 enablers, and then the way forward.
Yeah. I thank you very much. Thank you, WHO, for this opportunity to me and for Rwanda Network of People Living with HIV. And thank you to the other presenters. The rollout process of community engagement tour conducted by Rwanda Network of People Living with HIV, RRP+, in collaboration with the International Treatment Preparedness Coalition, ITPC, and the HIV Coverage Quality and Impact Network, SEQUIN, has helped to support decision-making and programming, providing a valuable insight on the status of community engagement in differentiated service delivery, DSD. So let's talk about 2 key challenges met during the community engagement rollout. One is the limited supervision that include recipients of care, readers, and representatives. Actually, the data collection revealed a significant challenge in the joint supervision of DST intervention by recipients of care, readers, and their representatives in the DST implementation at district and sector level in 67% of all the DST health facilities due to the lack of financial support for the involvement of recipients of care, readers, and representatives to join supervision. This creates a gap in DST sensitization about the existing services, demand creation, monitoring and evaluation of activities, as well as the follow-up of recipients of care, satisfaction of the quality of services. The second one is the limited feedback meetings gathering both recipients of care, healthcare providers, and other duty bearers. The same 67% of health facilities do not have the financial means and the platforms for organizing feedback meetings to discuss the process and the remaining barriers in the DCST implementation. 2 enablers. The data collected revealed a high-level policy engagement, high policy level engagement of recipients of care. Here we commend the political will of the government of Rwanda through the Ministry of Health and Rwanda Biomedical Center to engage recipients of care in national HIV technical working groups, strategic plan in guideline design, review, and monitoring. The recipients of care demonstrated a commendable level of engagement at policy level with 100% of participation. Second one, it's comprehensive methodology for the community engagement data collection. Designed by ITPC, the tool spans the 3 levels of a policy, program, and community through the design, implementation, monitoring, and evaluation processes. This approach allowed a holistic understanding of the community engagement dynamics. It's important to note that prior to the rollout of the community engagement tool by RRP+, intervention for people living with HIV were often perceived as a charity rather than a fundamental right. However, through comprehensive community engagement, understanding, recipients of care have significantly amplified their engagement, embracing their responsibility to HIV response. The way forward is to continue advocacy from national level up down to facility level to address the gaps in the implementation of DST program, ensuring equal community engagement at health facilities, and by scaling up platform for feedback meetings for all facilities. The second one is the training of the recipients of care, readers, and peer educators at all levels on the community-led monitoring in order to continuously play a constructive role in response. Last but not least, it's the community priority for funding requests as a result of Rwanda being one of the top 5 countries, having already achieved the 95 UN target. Funding for HIV response will decrease. Community-led monitoring should be among the priorities for funding requests to key partners such as Global Fund, PEPFAR, to maximize the HIV programs efficient and sustainable impact. I thank you very much.
Thank you. Thank you so much, Jean, for sharing that experience from the RP in Rwanda. And I believe this would help other countries also begin to use community, civil society data to improve differentiated service delivery implementation, which is one of the key things that we recommend as WHO. Thank you very much for sharing that experience. We'll now move to the Global Fund. You know, one of the wisest men that ever lived wrote this, and I quote, "A party gives laughter, wine gives happiness, and money gives everything." So we are privileged to have Amer, who comes from the agency that holds the purse. So the Global Fund basically has been very supportive of differentiated service delivery efforts. Over the past 3 years, as we all know, the DSDSI, as we've come to call it, has been a very, very impactful and helpful intervention that the Global Fund has supported. In addition to that, the guidance note, the HIV information note, and all the key guidance from the Global Fund for the GC7 grant have highlighted the importance of countries implementing DSD interventions. Ame, what is your support to DSD now that the SI is over? What do you see as the data gaps?
Yes, thanks very much for the opportunity to speak today. I think before answering that, I should really say thanks to WHO, to all the partners, particularly the countries that have worked with us with such dedication throughout the DSDSI to achieve, I think, some really great results. So we really, you know, as Global Fund, we really thank you sincerely for that collaboration. I think the thing I should really highlight, because the DSDSI has ended, that definitely does not mean that the Global Fund support for DSD has ended. In fact, and I'm sure many of you have worked with country applications, and you've had to go through our not inconsiderable process of putting together a funding application. But if you look at the HIV information note, you'll see that DSD approaches are critical approaches within the HIV information note. We pick out 2, having diverse settings for delivery of services and having differentiated treatment, in particular MMD. I know DSD is a much broader umbrella of many things than that, but we had to pick 2. That has some concrete implications for how we work as the Global Fund. So every country that makes a funding application is required to outline its progress in those areas of DSD. And the Global Fund commits to supporting countries throughout the entire grant cycle when it comes to DSD, the funding request development, the grant implementation, and the sustainability of the grant. So in summary, Global Fund strongly supports, through our endorsement of WHO guidelines that we want to see embodied in the applications, DSD. So I hope if I can make one message on behalf of Global Fund in this short talk, and I'll try and be short to allow some time for discussion. I hope it's that. Okay, so in terms of data, I think that's a very interesting question. I think for a lot of for a lot of the time we've been working in DSD, we've maybe not been working in that data-rich space. But I think there's a lot of things that would be good to know more. It was great to hear from Dr. Seville about the great results you're having in terms of the proportion of people on DSD. I think for a lot of countries, what we do know is we do know that there's support in policy and guidance for MMD. So if I could sort of focus in on MMD as one component of differentiated service delivery within differentiated treatment, we know that the policies are there for 3 months and increasingly 6 months MMD. I think what we have a less clear picture on is the number of people within countries who are accessing 3 and 6 months MMD. And I know from some of the data we've seen from some countries, it's not as high as we might imagine because there are some restrictions on people getting 3 and 6 months. And I know there's a new UNAIDS GAM indicator on that, but it's maybe not, and we hope that completion and reporting on that GAM indicator improves. I think one other thing that Global Fund supports and would be very interested to understand better in the data is how we are doing on multi-month dispensing for other commodities, which we saw as being incredibly important during COVID. And now there are great opportunities to synergize that. It's great if someone doesn't have to go to the ART clinic every month, but if they still have to go every month for their cardiovascular medication, their TB medication, their whatever it may be, we've kind of defeated the purpose as far as it counts for improving people's lives. And we know that a lot of loss of income and inconvenience goes with that. Attendance, frequent attendance to clinics, we cannot underestimate, is a significant thing for people in their lives. I think something I've always been very interested in is choice. So we talk about all these choice of DSD models. Do we know if choice is actually being offered at the clinic level? Because I have to say, when I go to clinics, and before I worked for the Global Fund, I actually spent a lot of time in clinics. You don't actually get a lot of choice in a lot of clinics. You're told what you're getting. So I think a really interesting question is, to what extent are we successful in offering people a choice of a DSD that meets their needs and preferences, and in doing so, hopefully keeps them well and virologically suppressed and in care for longer. I think we heard about community-led monitoring. I was asking around actually before this talk, we do actually have some examples of community-led monitoring being quite useful in unpicking that choice and people actually telling us, yes, I did get a choice, or no, I didn't get a choice. So maybe community-led monitoring can help with that. I think community-led monitoring is something we really have to maximize the potential there. Global Fund is funding it. So let's really make the most of that to get a genuine community perspective, and not a tick box exercise, but something real that's telling us how recipients of care feel about the care, and does it meet their needs? And then maybe just finally, I'd be very interested to know how we're doing on DSD for AHD and how that's going. In this cycle, Global Fund's supporting a lot more commodities for AHD than it was in the previous cycle. And I hope at some point in the future we can share some of that data. And then the other thing is welcome back services. I don't know how much we talk about that in the context of DSD, but that's, this cycle, the contemporary ART engagement is not a linear cycle that we had this image of in our past. We know much more, and great work Siders have done on this in Zambia. It's a much more cyclical process of continuing disengagement and re-engagement from care. And how is DSD not just supporting the retention, but supporting the re-engagement that I think we have to acknowledge is over the long term is actually a reality that we have to better address. So I will stop there, and interested in the discussion if we have time for discussion. Thank you.
Thank you. Thank you very much, Ahmed. Thank you. Very, very insightful points there on, especially on the gaps, and it's good and to hear that though DSDSI has ended, the grants would continue to support DSD interventions and TAs so that are needed to scale up differentiated service delivery. Thank you very, very much. Those are, let's give the panel another applause. Sally, I don't know if we have some time. Great. So we can have some comments and questions from the participants. Can someone help us with a microphone, please? Yes, it's coming from the back. So let's please keep our points or questions very succinct so others will have the opportunity.
Thank you very much. Elizabeth from Ghana. I just wanted to ask Zambia how they are able to track their clients, even though they may move around from one place, one province to another, how nationals is still able to follow up that one individual no matter where they go. Thank you.
Thank you. Thank you. That was straight to the point. Any other? Yeah. So we'll take about 3 and respond to them, and then we take another round.
Thank you very much. I'm Kevin Zongo from Burkina. I have one question for Zambia presenter. I saw the data, but I think the prevalence is still high. What is currently done in Zambia to reduce this prevalence? Thank you.
Thank you. Any other? Thank you. There's a hand here. Okay, so from there we come back.
Yeah, my name is Gaspar Mbija. I just have one questions or comment for everyone regarding to biometric or fingerprints as it comes to the patient's monitoring and the tracking. So can anyone comment around that? Where are we?
Thank you. Great panel, straight to the point questions. So Zambia, we want to take those two. I'm wondering who will take the last one. All right, he wants to help us with that. Okay.
Yeah, so obviously the best way would be some form of biometrics to track a patient from province to province. I think it's a similar question. But what we are doing, we are using like letters from the name of the patient, and also their NRSC and the number that is generated by the system. Yeah, so like I said, at facility level, we find that the retention or the loss to follow-up will be probably slightly higher, maybe like 8% or so. Once you start going up, because the data does merge, as you are going at maybe sub-national level, the number that we have is about 6 to 8%. But we've done analysis at the national level where all the records are from month to month. It's moving from 3 to 4%. Yeah, and the codes that we are using is what I've mentioned. Some letters from the name, numbers from the system that it generates, and also the NRSC numbers. But fewer patients, remember, that are lost to most of the majority are not lost to follow-up. Prevalence 11%. Oh, I can say that it used to be 20% in the past. Yeah, so it's coming down, and probably it's not the biggest marker of our performance. Is maybe the incidence, which we've in the last 5 years has halved from about 0.6 to 0.3. Now if you look at the different fears, yeah, and biometrics, maybe somebody can mention on that.
Okay, yeah, I can take the question on biometrics. So obviously, there's benefits of biometrics in terms of being able to uniquely identify individuals across different facilities, but those really need to be weighed against the potential risks, and they need to be strong safeguards for data security, particularly in countries where key populations are criminalized. And so currently the WHO SI guidelines in these settings do not recommend biometric data or certainly the storage of biometric data. So there are various ways of separating the biometric data and being able to use that to verify the identity of a client, but not actually storing that information to deal with some of these security risks. So it does require careful thinking of these data security issues and making sure that there are safeguards in place. But there are also other methods in terms of unique identifiers that don't rely